Hello everyone, my name is Cucumber Boy, and today I'm going to be reciting more medical facts for you. Starting with acute reactions in under 24 hours, febrile, non-hemolytic, pause transfusion, give antipyretics, if allergic give antihistamine steroids, patient can end up with anaphylaxis, transfusion related acute lung injury, supportive care, delayed hemolytic transfusions, reaction supportive care, transfusion associated graft versus host disease, supportive care, post-transfusion purura, intravenous immunoglobulin, management, stop transfusion immediately if suspected, fluid replacement with normal saline to maintain renal perfusion and prevent renal failure, maintain urine output of 100 ml an hour. Mannitol can be given for forced diuresis. If progressive acute renal failure, consider dialysis. Acute renal failure, acute respiratory failure, hypothermia, thrombocytopenia, and death. May occur in those who have been immunized previously to RBC antigens during pregnancy or transfusion. As transfusion occurs, RBCs containing the antigen create a secondary immune response that raises the antibody level, causing rapid hemolysis of newly transformed cells, resulting in the patient presenting with fever, anemia, jaundice, and hemoglobinuria up to 10 days post-transfusion. Next question. A 5-year-old boy has been feeling unwell for the past 3 weeks. He complains of general weakness and aches. On examination, he is febrile with mouth ulcers, mild pallor, and purchase on his chest. He also has painless and palpable widespread lymphadenopathy as well as mild splenomegaly. Most likely diagnosis is acute lymphoblastic leukemia, ALL. ALL, which is clinically indistinguishable, small cell lung cancer, reactive lymphocytes, lymphoma, B-cell, mantle cell, non-Hodgkin, full blood count of anemia, leukocytosis, neutropenia, thrombocytopenia, blood smear, bone marrow aspiration, and tree-fine biopsy, and lymphoblastic infiltration. Lymphoblast, serum electrolytes of increased sodium, increased calcium, increased potassium, increased uric acid, increased lactic acid. Renal and liver functions are abnormal. Coagulation studies indicate mild coagulation. General fatigue and malaise, bone and joint pain, recurrent infections and non-specific infective signs, fever of unknown origin, hepatomegaly, lymphadenopathy, palli, pachai, CNS involvement. The treatment is long-term chemotherapy approach and a heavily dependent on age, with 70 to 90% cure rate on children compared to 40% in adults. Prognosis is usually poor if there are CNS signs present of Philadelphia chromosome, pancytopenia, febrile neutropenia, tumor lysis syndrome, chemotherapy, toxicity, and alopecia are some of the complications. In comparison with AML, often clinically indistinguishable, AML is diagnosed as 20% more myoblast, rods in blood film, and bone biopsy. AL is more common in children with a peak innocence rate of 2 to 5 years old. Next question is, a 70-year-old man presents with a 2-month history of fever, fatigue, and weight loss. He also reports frequent epistaxis, abnormal fullness, and early satiety. Chronic myeloid leukemia. Most likely diagnosis. Differential diagnosis can be leukemoid reaction, essential thrombocytopenia, polycythemia, He's afebrile, but has mild splenomegaly. An FBC shows elevated white blood cells and low hemoglobin. His blood film is shown. The most likely diagnosis is chronic lymphatic leukemia. Differential diagnosis can be autoimmune hemolytic anemia, mantle cell lymphoma, follicular lymphoma. Patients are often asymptomatic and are often diagnosed incidentally via routine blood tests for unrelated reason: weight loss, fever, dysphoresis, hypomegaly, recurrent affections, for blood count cell of lymphocytosis, anemia, thrombocytopenia, blood smear, smudge cells, flow cytometry to detect surface immunoglobulins, CD5, CD19, CD20, CD23. Risk factors are being more than 60 years old, male, having a family history, being white and ethnicity, being 85 to 89 years old, right staging system, 0 stage lymphocytosis alone, first stage and lymphadenopathy, second stage and hepatomegaly, third stage and anemia and IV, 5 thrombocytopenia. Symptomatic, rapid progression of disease with rapid enlargement of lymph nodes and organs, immune thrombocytopenia, purpura, and autoimmune hemolytic anemia. Treatment depends on the RI staging, with 0 to 2 stages requiring close observation and 3 to 5 requires chemotherapy.